This podcast is sponsored by Zoll LifeVest. Zoll has continuously improved LifeVest for over 20 years, leading to a median real-world wear time of 23.4 hours per day and an AI-enhanced algorithm that delivers zero median false alarms at 90 days. The newest LifeVest garment is lightweight, breathable, and preferred by patients for its comfort. Learn more at lifevestinnovation.com.
Hello, CardioNerds. Dan Ambinder here. This episode is a part of a series of fascinating case reports developed in collaboration between CardioNerds and the National Lipid Association with mentorship with Dr. Daniel Soffer and Dr. Eugenia Gianos. But before we get started, I'd like to bring in our special guest host for the second time, Dr. Devesh Rai, who is the chair of the CardioNerds Cardiovascular Prevention Committee. Devesh, so glad you could join us. And thanks so much for your leadership on this collaboration.
Dan, it's a pleasure to be here, and I'm so excited to discuss lipidology today. These cases are put together by National Lipid Association lipid scholars, and joining us today are Doctors Oby Ibe and Elizabeth Epstein. Please introduce yourself, including how you joined NLA and how the Lipid Scholar Program fits your career goals. National Lipid Association runs a Lipid Scholars Program, which aims to mentor and educate trainees to work towards certification during their training, getting more certified lipidologists and professionals into clinical practice. We are really excited about lipids and hope you'll be too. Liz, why don't you introduce yourself?
Hi, everyone. I'm Elizabeth Epstein. I'm a second-year cardiology fellow at Scripps. I'm also pursuing a simultaneous integrative fellowship at the same time. And I am so excited to be part of this podcast today and also part of the NLA Lipid Scholars Program. I had an incredible mentor when I was a resident at UCSD, Mike Wilkinson, who recommended this program to me, and it's been such a safe haven for someone who is as obsessed with lipids as I am. They also help us do training to get our lipidology certification, so it's fantastic.
Hi everyone, my name is Oby Ibe. I am a third-year cardiology fellow at Temple University Hospital with interests in preventative cardiology, lipidology, cardiovascular imaging, and quality improvement. I'm committed to identifying social determinants of health, advancing equity in cardiovascular care, and promoting diversity within the field of cardiology. I'm excited to be starting a general cardiology faculty position at Penn Presbyterian Medical Center in West Philadelphia this fall. I'm so thankful that one of my mentors saw the potential in me and the passion I had for preventative cardiology and encouraged me to apply for the Lipid Scholarship Program. Through this scholarship, I have met lifelong mentors, seen cutting-edge anti-lipid therapies through our sponsored scientific sessions every year, expanded my lipidology foundation by taking the foundations and master's courses for free, and have received support to pursue certification in lipidology. This opportunity has positively impacted my patients' care and has aided me in attempting to decrease the racial and gender-based disparities in dyslipidemia. I'm looking forward to continuing to learn from pioneers in this field and to help disseminate this knowledge to my patients and colleagues.
Thanks a lot, Liz and Oby, for introducing yourself and telling us about the incredible Lipid Scholar Program run by NLA. It is indeed a wonderful opportunity. Liz, why don't you tell us about the case?
With Lp(a) lowering drugs on the horizon, we've got a fascinating and very relevant Lp(a) case to talk about today. Another really interesting aspect of the case is that it involves a young woman with upstream risk factors, requiring us to think not just about her 10-year risk, but her lifetime risk, especially with elevated Lp(a). So let's jump into the case. Our patient is a 34-year-old female who presents to your outpatient practice because she heard on the radio that her heart disease can affect young people as well and wants to make sure her heart is working well. Her past medical history includes PCOS and depression. She has no known history of hypertension, diabetes, hyperlipidemia, tobacco use, or a family history of cardiovascular disease. She does not do any illicit drugs and has 1 to 2 drinks a week. She works as a marketing executive, has been working with a nutritionist for the last few months, and exercises 3 to 4 times a week for 40 minutes.
So what are some female-specific risk factors we should ask about? So for this patient, she had her menarche at an early age of 10 years old. She was diagnosed with depression 5 years ago with no major depressive episodes and takes sertraline 50 milligrams daily. She's had PCOS for 10 years and has not required any medical therapies. She had 1 normal pregnancy at the age of 30 years old with no preeclampsia, gestational diabetes, hypertension, or preterm delivery. Her baby was of normal weight. She has never been tested for any anti-inflammatory diseases, and she is of African descent. On exam, her BMI is 31 kilograms per meter squared. Her blood pressure is 121/72. Her heart rate is 82, and she's setting 98% on room air. Overall, she has a normal physical exam, and her EKG is normal sinus rhythm.
So, what are factors associated with increased risk of CVD for this patient? One is PCOS. So, PCOS is a disorder characterized by hyperandrogenism and menstrual irregularities. Women with PCOS have an increased risk of developing diabetes due to associated insulin resistance, central obesity, and hypertension. This adverse cardiovascular risk profile in women with PCOS may lead to premature atherosclerosis, and women with PCOS have been shown to have increased risk for CVD events. Next is depression. So, among 593,616 young adults aged 18 to 49 years that were followed from 27 to 2020, depression was independently associated with CAD and suboptimal cardiovascular health with a dose-response relationship.
So the next risk factor is early menarche. Results from the Women with Ischemia Syndrome Evaluation Study demonstrate that in comparison to women with menarche at age 12 years old, there's approximately four-fold adjusted increased risk for major adverse cardiac events for menarche less than 10 years old. Our patient is also of African descent, and Stafford et al. Found that among those at highest CHD risk, Black women's hyperlipidemia were the least likely to be treated or controlled. Lp(a) is significantly higher among Blacks versus whites, and in both, increased Lp(a) correlates positively with LDL-C and negatively with triglycerides. Another study based on the MESA population demonstrated that Black participants showed significant risk of CHD in those with Lp(a) levels greater than 75 nanomoles per liter, as opposed with white and Hispanic patients who had a greater risk with Lp(a) levels of 125 nanomoles per liter. And lastly, in terms of elevated BMI, obesity and higher measures of central adiposity are associated with significantly higher rates of CAD, CVD mortality, sudden cardiac death, heart failure, and arrhythmias. High BMI accounted for 4 million deaths in 2015, more than two-thirds of which were caused by cardiovascular disease. Marked increases in obesity prevalence among adolescents over the past 35 years ultimately contribute to CVD risk in young adulthood.
But these risk factors don't fit into a calculator. So, how do we incorporate these into our 360-degree risk assessment? The reality is that an individual's risk is much more complicated than a calculator. A calculator is a good place to start, but then we can decide whether the calculation under or overestimates the risk based on everything else we know. And we'll talk more about risk calculators after we review our patients' labs.
Thanks a lot, Liz and Oby, for presenting this case. This case is really interesting about how a young 34-year-old woman is coming to the clinic just for a preventive cardiology checkup. We often see these patients in our clinic here and there. What's really interesting is the way you guys presented the OBGYN history regarding her early onset of menarche, about her pregnancy, and there are no complications. This is very important, and when we are seeing young age patients, and we should always ask this history. In my experience, often when I've asked patients, they have been like, why this heart doctor is asking me questions about my menstrual cycle? But then after explaining the patients regarding the importance of OBG history in cardiovascular health, they're open about it. So let's talk about the labs.
The patient's labs were normal with the exception of A1C of 5.8, total cholesterol 189, triglycerides 134, HDL 34, LDL 131, VLDL 24, and an Lp(a) of 217 nanomoles per liter. So let's delve into her risk assessment. What calculator would you use with this patient? First off, we recognize that calculators are not perfect, but they're a place to start. A recent paper in European Heart Journal looked at how often Framingham, pooled cohort, SCORE2, and MESA agree, and concordance varied from 19 to 85%. Oof, I think we have more work to do with developing the ultimate risk calculator. But there are a couple new calculators out recently that have really interesting aspects.
So, as we know, the pooled cohort equation predicts 10-year risk of ASCVD in non-Hispanic African American and non-Hispanic white men and women from ages 40 to 79 years old. The American Heart Association just released the PREVENT calculator, which stands for Predicting Risk of CVD Events, which enables 10 and 30-year risk estimates for total CVD, which is a composite of atherosclerotic CVD and heart failure. It was created with data sets that include over 6 million U.S. adults age 30 to 79 years of age, so it's very generalizable. The calculator includes estimated glomerular filtration rate as a predictor, adjusts for competing risk of non-CVD death among adults 30 to 79 years of age, and incorporates cardiovascular, kidney, and metabolic risk factors, and also has an indicator of social determinants of health. Race was not included because it is a social construct and not a biological risk factor and could therefore create bias. 3 research teams were just awarded $150,000 from AHA to further study how the risk calculators perform among people of various ages, racial and ethnic backgrounds, locations, and socioeconomic levels.
A universal calculator was also recently published in JACC. This was unique because it could be used in patients both with and without CAD, doing away with the concepts of primary versus secondary prevention and placing everyone on the same spectrum of risk. The calculator incorporates the points of ASCVD versus no ASCVD, age, diabetes, SBP, hypertension treatment, total cholesterol, smoking history, CRP, NT-proBNP, high sensitivity troponin T, and provides a 5 and 10-year risk assessment of MACE. The calculator was able to identify patients without CAD who actually had a higher risk than those with prior CAD. This calculator is not yet available online, but the authors did publish their formula, so could be plugged into Excel. I think it's clear we're making major strides in risk estimation.
So, unfortunately, our patient doesn't fit into the pool cohort equation due to her age. If we calculate her prevent score, her 10-year ASCVD risk is 0.5%, and her 30-year risk is 3.5%. Her 10-year risk is also 0.5% by the Q risk score. Using 2 different calculators that include young patients, we are finding her 10-year risk to be very low. But obviously, let's get to the elephant in the room here. Where does this patient's Lp(a) fit in? Hers was 217 nanomoles per liter, and normal is less than 75 nanomoles per liter. How does this impact her risk? First, a little background on Lp(a). Lipoprotein A is a low-density ApoB containing lipoprotein cholesterol, like KETCHL, as a genetically determined marker of cardiovascular disease and calcific aortic stenosis, and acts through induction of vascular inflammation, atherogenesis, calcification, and thrombosis. Elevated Lp(a) levels are associated with a residual cardiovascular risk despite traditional risk factor optimization. Although statins can increase Lp(a) by up to 30%, this has inconsequential effects on incident CAD, and the benefits of minimizing the risk attributed to LDL-C outweigh those risks. But in the Fourier and Odyssey outcomes trials, PCSK9 inhibitors demonstrated that Lp(a) lowering was an independent contributor to MACE reduction. Thankfully, multiple therapies that have potent Lp(a) lowering effects are on the horizon.
Observational studies have shown that elevated Lp(a) is associated with long-term MACE in both patients with and without cardiovascular disease. The 2019 consensus statement from Heart UK categorized the impact of cardiovascular risk associated with Lp(a) as minor, moderate, high, or very high based on the level of Lp(a). The European Atherosclerosis Society has also published a consensus statement on Lp(a) in the European Heart Journal, which includes a useful table to quantify how much Lp(a) increases 10-year risk based on the baseline risk and the Lp(a) level. Using this table, our patient's 10-year risk increases from 0.5% to 4.5%. This is still a low 10-year risk. However, the prevent score also gives us her 30-year risk, which was 4.5%. So her Lp(a) could potentially increase her 30-year risk to 31.5%. It makes us worry that when this patient reaches her 50s and 60s, she could start to get into trouble.
Exactly, Liz. In fact, longitudinal studies have demonstrated that the presence of cardiovascular risk factors at young ages, 20 to 39 years old, accelerates the development of CVD in late adulthood. According to the Pena study, participants with LDL-C as low as 70 micrograms per deciliter demonstrated subclinical atherosclerosis in some cases affecting multiple vascular territories. The risk of subclinical atherosclerosis was 11% in patients with an LDL of 60 to 70 to 64% in the 150 to 160 milligrams per deciliter group. Triglyceride levels greater than 150 have also been associated with higher risk of subclinical atherosclerosis. In addition, Longer exposure to elevated LDL-C has been associated with increased risks of CVD in a concentration-dependent fashion, independent from other risk factors, and the same cumulative LDL-C exposure reached at a younger age resulted in greater risk increase. So based on all of this, the randomized controlled study, PRECAD, which stands for Prevent Coronary Artery Disease, will assess the potential benefit of an aggressive control of cardiovascular risk factors in otherwise healthy young adults. The hypothesis of PRECAD is that in subjects aged 20 to 39 years old, without any known CVD, maintaining an LDL less than 70, a systolic blood pressure less than 120, and an A1C less than 6.5% will prevent the onset of atherosclerosis and/or its progression. The primary endpoint will be the change in total atherosclerosis burden, a surrogate for CVD.
I am so excited to see the results of that study. Based on the information we have so far about this patient, currently the AHA-ACC guidelines would not recommend treatment for this young woman. There's some newer data suggesting that in patients with coronary artery disease, aggressive LDL lowering down to 50 can reduce the risk of Lp(a) by up to 50%. LDL of 50 is pretty aggressive for this patient, which makes sense in very high-risk patients with existing CAD. However, it may not apply to a young primary prevention patient like ours. I wonder what preventive cardiologists and lipidologists are currently recommending for young patients with high Lp(a). Beyond the question of LDL lowering, we know that lifestyle change plays a big role in Lp(a) patients specifically. While it was previously thought that lifestyle has no impact on Lp(a), in fact, it very much does. It doesn't lower Lp(a) directly, but following the AHA Life Simple 8 lowers the risk of Lp(a) by 66%.
What about disease burden? Would it be helpful for our patient to have a calcium score? So there are currently no clinical trials assessing the utility of a CAC score as a tool for risk assessment and decision-making in young adults. However, in the presence of multiple risk factors, nearly 1 in 4 young men and 1 in 6 young women have detectable CAC, which is associated with higher rates of all-cause and coronary-specific mortality. Though Habib et al. Developed a calculator for age, sex, and race-based CAC percentiles in the 30 to 40-year age range, derived from 3 large cohorts, and based on this, he created a CAC percentile calculator for individuals aged 30 to 45 years old. Ikikwat et al. Proposed a conceptual, non-evidence-based flow sheet for using CAC scores for primary prevention of ASCVD events in young adults. In addition, coronary CT angiography has also been discussed because it can identify non-calcified plaque as missed by a CAC score, though cost and feasibility limits its use in trials. What do you typically do, Liv?
In a young woman, a calcium score is not as helpful because subclinical atherosclerosis may not yet be calcified. But it's always good to consider any subclinical atherosclerosis that may exist. While the radiation is usually only equal to a third of a mammogram, per guidelines at this point, it's not recommended in patients under 40 years old unless they have FH. Rather than obtain a calcium score, this would be a good opportunity to capitalize on any other incidental imaging the patient has had, such as a CT abdomen, abdominal ultrasound, or even a mammogram, and go searching for any visible plaque.
In a young woman where we are looking for early development of plaque, ultrasound is particularly useful. While not recommended in the guidelines, ultrasound can be considered in young people because young people build soft plaque first rather than calcified plaque. Cole et al. Looked at the carotid ultrasounds of over 2,000 patients, 26% of who were under the age of 50 and 56% of who were females, that were considered low to intermediate Framingham risk, and found that 25.1% of individuals were reclassified to a higher risk due to the presence of carotid atherosclerosis. We know that carotid plaque burden independently predicts MACE, and aortic and femoral ultrasounds also predict MACE and can be used to monitor for early development and progression of disease.
Our patient did not have any carotid plaque. So what's the verdict on her LDL lowering? Will we treat her LDL? Because of her risk factors and suspected high lifetime risk, we still recommend LDL lowering to less than 100, and of course, following Life Simple 8. What medication was started on this patient, Oby?
After a patient-provider risk-benefits conversation, patient agrees to start on low-intensity rosuvastatin to try to avoid any side effects and see where that gets us. Her LDL will be rechecked in 4 to 6 weeks with the goal of less than at least 100. And she'll inform the team if she is planning any future pregnancy so that her statin can be stopped 4 to 6 weeks prior to conception per the NLA guidelines. She'll continue a Mediterranean diet and physical activity, and she'll advise her family to also have their lipid panel and Lp(a) checked.
Now, what about aspirin?
So, in an observational propensity match study looking at MESA patients without any baseline cardiovascular disease, aspirin use was associated with significant reduction in risk for cardiovascular events among those with a lipoprotein A greater than 125 nanomoles per liter. Due to the atherothrombotic properties of lipoprotein A, aspirin could have a significant impact for primary prevention, but at the moment, more randomized studies are needed before we could recommend aspirin. And our final question, do you think this patient would be a good candidate for pelacarsen, Liz?
That's a tough question. Olpasiran or pelacarsen is a small interfering RNA molecule that disrupts expression of LPA and prevents assembly of the Lp(a) particle in the hepatocyte. O'Donoghue et al. Found that for patients with atherosclerotic disease, subcutaneous 12-week dosing of olpasiran over 36 weeks reduced the Lp(a) concentration in a dose-dependent manner, with doses of 10 milligrams or higher reducing the circulating Lp(a) concentration by more than 95%.
That's amazing. So we'll have to see what the trials show for patients like ours, but I have to think she may be a good candidate for Lp(a) targeted treatments. This is a good start for this patient, and we'll continue to monitor her as she ages. Should she develop any plaque, we'll definitely need to be more aggressive.
Thanks a lot, Liz and Oby. This was amazing. I learned so much from this discussion and definitely a lot of things to go back and learn more. So in a nutshell, this case was really interesting. We had a young age 34-year-old patient who's physically active, coming mainly today for preventive cardiac checkup, and her blood cholesterol levels are significant for LDL of 131 and lipoprotein A levels of 217, which is very, very high for sure. This was very interesting to see in this patient that how Lp(a) levels increase her risk of having any future ASCVD dramatically. And the other interesting part is like how LDL is not the perfect marker to show how future ASCVD will occur. Like as in the PESA study, it has shown that patients with even like 60 to 70 of LDL levels have had subclinical atherosclerosis. So in this patient, one of the things which we can definitely recommend is AHA simple 8 to lower the risk of Lp(a), and it has shown that even though they don't directly decrease the Lp(a) levels, but it can decrease more than 50%. Moving forward, in these patients, the role of coronary artery calcium score in a very young patient is not very clear, but we can also always look at any other imaging done like mammography or CT chest or CT abdomen and see if any calcifications are there and go from there. Because these patients do not tend to have a lot of calcification, so we can always consider carotid ultrasound, which can help us identifying the soft plaque and help us to be very aggressive with risk factor modifications. I'm really excited to see the results of olpasiran or pelacarsen in future to see if we have Lp(a) targeted therapies and how they help in risk factor modification and primary prevention. But this was amazing. Liz, why don't you go ahead and introduce our expert for this case?
Dr. Jessica Pena is a cardiologist specializing in the prevention and treatment of heart and vascular disease and management of cardiac risk factors. She works with patients to identify their risk factors for heart disease and develop personalized strategies for lowering their risk of developing heart disease. She has a particular clinical interest in heart disease in women and a comprehensive evaluation. She takes into account the important social and biological differences between men and women that contribute to the development of heart disease.
Hi, I'm Dr. Jessica Pena, a cardiologist and lipid specialist at Weill Cornell Medicine in New York. Thank you for the invitation to comment on a patient very much like the people I see in my clinical practice, Heart Health, a clinical cardiovascular prevention program. I'm very pleased to see the focus on a young person in this case because we know that small changes or improvements in cardiovascular risk factors really accrue over a lifetime. So it's never too early to think about ways to mitigate cardiovascular risk. The case presented of a young woman with elevated Lp(a) raises several questions that Liz and Oby have summarized nicely in their discussion, namely how to assess risk, who to treat, when, and how. The patient presented has a salutary lifestyle and is concerned about her cardiovascular risk in the setting of factors associated with increased risk, such as early menarche, depression, PCOS, elevated BMI, low HDL, elevated LDL, elevated Lp(a), and elevated blood pressure. Although some of these factors don't fit into our risk calculators are a great place to start the conversation about cardiovascular risk. And the New American Heart Association Prevent Calculator has the great advantage of allowing for risk prediction in younger patients like the patient presented in our case. The PREVENT calculator was developed in a sample of over 6 million people using over 40 cohorts, reflecting both research and clinical settings, so really a broad population. In addition to traditional risk factors such as blood pressure, cholesterol, smoking, diabetes, antihypertensive or statin use, and BMI, it also incorporates kidney and metabolic disease using the estimated GFR, with the option of incorporating urine albumin to creatinine ratio. The calculator also includes the option of incorporating the social deprivation index calculated at the zip code level, recognizing that social determinants are really critical drivers of cardiovascular health. The calculator also predicts the risk of both ASCVD or atherosclerotic vascular disease and heart failure, emphasizing prevention of heart failure as an important outcome. I look forward to this calculator being incorporated into the electronic medical record to facilitate clinical implementation and further studies evaluating its performance. Going back to the patient presented and her risk factors, although her blood pressure does not meet thresholds for pharmacotherapy based on current guidelines, it's important to note that her systolic blood pressure is elevated at 121 millimeters of mercury, and that cardiovascular risk increases linearly with elevated blood pressure. Self-measured or ambulatory blood pressure monitoring could be pursued to evaluate this further and exclude mast hypertension. Self-measured blood pressure has been shown to be a better predictor of cardiovascular outcomes compared with office blood pressure and may be a good option for this young patient who may not have as many in-office clinical encounters. Her BMI is elevated at 31 milligrams per kilogram squared. Measurement of waist circumference would be helpful as it provides a measurement of abdominal or central adiposity, which we know is associated with increased risk of cardiovascular disease and metabolic-associated steatotic liver disease that is independent of BMI. It's also practical and easy to implement in clinical practice. Obesity, central adiposity, insulin resistance, chronic low-grade inflammation, hypertension, dyslipidemia are all common in women with PCOS, and the extent to which the increased cardiovascular risk associated with PCOS is due to the cardiometabolic risk factors associated with the condition or PCOS itself is unclear. Another biomarker that may be useful in risk stratification, particularly understanding the risk related to inflammation, is high-sensitivity CRP. We know from the Jupiter trial that women over the age of 60 and men over the age of 50 with an LDL less than or equal to 130 milligrams per deciliter and an hsCRP above 2 milligrams per liter had a 44% reduction in the risk of major adverse cardiovascular events when randomized to rosuvastatin as compared with placebo. And in a subsequent analysis by Kerr and colleagues, the risk reduction associated with rosuvastatin was shown to be similar among those with both high and low Lp(a). Another biomarker, apolipoprotein B or ApoB, may also be helpful in determining the total burden of atherogenic lipid particles for this patient. Now, going back to our case, there are some additional aspects of measuring Lp(a) that are important to remember. First, most major societies, including the National Lipid Association, now recommend Lp(a) be checked once in all adults and selective screening in children with a history of familial hypercholesterolemia, stroke, family history of elevated Lp(a), or premature ASCVD. It's preferable to measure using nanomoles per liter, which represents the particle concentration of Lp(a). And there's a gradient of risk associated with Lp(a), with levels under 75 nanomoles per liter or 30 milligrams per deciliter being categorized as low risk, 75 to 125 nanomoles per liter as intermediate risk, and greater than 125 nanomoles per liter or 50 milligrams per deciliter as higher risk. Although levels are generally stable, there can be some variability with levels increasing during menopause. It's also important to remember that the calculated LDL measured in a lipid profile includes the cholesterol contribution of Lp(a). Elevated Lp(a) is common, being present in approximately 20% of adults with variation by ancestry. And since it's genetically determined, once you've identified someone with high Lp(a), it's important to counsel them that their first-degree relatives should be screened. Several studies have documented low rates of screening for Lp(a). The question of calcium scoring was raised in the case discussion. Some studies have shown that the risk associated with elevated Lp(a) is independent of the calcium score. Thus, a calcium score of 0 in the young person described would not be completely reassuring. In a recent single-center study of patients who underwent serial cardiac CT angiography with a median interscan interval of 10 years by Nur Muhammad and colleagues, higher Lp(a) was associated with higher plaque burden at baseline and increased progression of coronary plaque compared with individuals with low Lp(a), as well as a higher prevalence of low-density non-calcified plaque and pericoronary inflammation. Cardiovascular outcome studies of pharmacotherapies that potently lower Lp(a) are ongoing and evaluating patients with established ASCVD. If these trials show that lowering Lp(a) reduces ASCVD in those high-risk patients, the question that will arise is whether lowering Lp(a) in the primary prevention setting is also safe and efficacious, and if so, what groups benefit the most and what degree of lowering is needed. For now, our approach remains personalized and holistic, with control of the vascular risk factors that can be modified. Thank you again to Liz, Oby, and the CardioNerds for the opportunity to comment on this case.
Thank you so much for tuning in to this CardioNerds episode. The audio editing for this episode was performed by me, Christiana Dangas. I'm an intern in the CardioNerds Academy and a senior at Boston University. Check out the episode page for show notes and references. If you found this episode or the show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episodes. And now, my friends, it's time to make like an S2 and split.